The harmful nature of obesity is increasingly recognised, but exactly how it exerts its effect is poorly understood. In this month's EJC News Focus, Jean Alcio from the new I3S Institute in Porto told me about his research in pancreatic cancer.
We know now that obesity directly promotes cancer. So if you have a cancer, and we're talking about pretty much most types of cancer, obesity will aggravate the prognosis. So you will respond worse to drugs. We studied pancreatic cancer. The significance of obesity in different types of cancer varies, but they're normally tumor promoting, they have a tumor promoting effect.
What do you believe the mechanism is?
So there are many studies looking into this potential link, and a few groups have shown that metabolism may play a role via insulin and insulin growth factor signaling, and also through leptin. We have focused on inflammation. What we found was that tumors really enjoy being surrounded by fat, by adipose tissue, and obesity promotes inflammation locally and systemically, but this inflammation will then drive tumor progression. So we've identified pathways that basically are inflammatory pathways, and they use via different mechanisms, for instance, immune cell recruitment to the tumors, then lead to accelerated tumor progression, or these immune cells interact with cells that produce fibrosis, collagen, which then also prevent drugs from getting into the tumor. So we think inflammation is critical for this interaction between obesity and cancer.
Is the role of desmoplasia confirmed?
Well, we confirmed to some extent. Of course, in our mouse models, we've used different types of pancreatic mouse models. All of them were mouse syngeneic models, implanted or spontaneous. We also validated in patients, so we had histological samples from tumors, pancreatic cancers, and what we found was that there was increased accumulation of fibers, collagen and hyaluronan, in patients that have excess weight. And we also found that when we did a retrospective analysis of patients that received chemotherapy, we saw that the benefit of chemotherapy was less pronounced in obese patients. So in other words, since desmoplasia affects delivery of chemotherapy, we then validated in patients if in fact chemotherapy was less effective in these patients, supposedly because it's not getting into the tumors, and in fact consistent with more fibrosis, more desmoplasia in tumors in the obese setting. When the patients are treated with chemotherapy, then the effect is less in this obese setting.
Where does the research go next?
So I think one of the implications from these studies is that we need to consider the use of an obese, or at least an overweight mouse model, because that may better represent the reality of patients now, which is many of them will have excess weight at diagnosis. So I think we need to consider that we may be able to find or to make more findings in obese mouse models that are relevant for a patient. And then the results of our work, the conclusions from our work suggest that we can now use drugs that are particularly useful in the obese setting. So when patients are being selected to receive certain types of therapies, perhaps the body weight can be a parameter that can be used. If you combine chemotherapeutic agents with drugs that alleviate desmoplasia, so reduce fibrosis, then you can increase drug delivery to the tumors and have a better outcome, particularly in the obese setting, because there's so much more inflammation and fibrosis going on in the tumors. These antifibrotic agents are definitely valuable tools to be added in combination with chemotherapy. So not just by themselves, but giving a cytotoxic agent, so chemotherapy, and a drug that modulates the tumor microenvironment to make it less fibrotic, allowing the chemotherapeutic agent to penetrate the tumor better, then you will definitely have a better synergistic effect with a better clinical outcome.
It sounds like a very cheap way to improve care.
Right. So both metformin and a number of drugs that we use to target fibrosis are actually generic drugs, and they've been out there for many, many years. And so the idea was to repurpose them. It's still not very clear what is the impact of metformin overall in cancer, in pancreatic cancer progression. But we wanted to study in our mouse models and patient samples if metformin could have any impact. And what we saw was that if it's given to an obese mouse model, or if a patient that is taking metformin happens to be obese, then metformin is more effective, because metformin is targeting, according to our study, inflammation and desmoplasia in pancreatic cancer. And because these two parameters are increased in the obese setting, that means that these tumors in the obese setting are more sensitive to this drug.
Are there wider implications?
We think that, based on our studies, that when treating patients and selecting patients for specific therapies, or in clinical trial design, body weight and basically obesity and other parameters associated with body weight should be taken into account, because the patient may respond, for instance, worse to chemotherapy if they have excess weight, but may respond better to an anti-fibrotic agent if he has increased body weight, or may respond better to an anti-inflammatory agent if you have excess weight. So definitely our findings indicate that this should be explored in more detail in the clinical arena.
That's great. Thank you very much.